I'm trying to anonymize.
Recording. Let's see here.
I can go after you, Jeff, if you like to.
Sounds good. All right, so let's show my here. So David will like this case. This is a older man who's got a kidney transplant, and you should nope, you're not going to see that yet. Let's see. You should see a portable AP radiograph.
Good.
Okay, so he's a sort of an older man. I think he's in the 60s. He's had a kidney transplant, and he presented with fever, shortness of breath, cough, and a bunch of kind of pustular lesions and some ulcerative lesions on his skin. This is his chest radiograph from when he came in. You can see he's got kind of a generous heart, lots of nodules in the lungs, and then this loculated effusion here on the right. So you're worried about obviously a disseminated infection, maybe a component of edema given his kidney history and presumed cardiovascular history. I will show you his CT next, which hopefully you now see a CT.
Yep.
We see large nodules, we see micronodules everywhere, a little bit of septal thickening, but mostly, and then some denser consolidation. I'll show you the soft tissue windows to illustrate the fact that we do have this loculated effusion, but there's lymphadenopathy is sort of conspicuously absent. He's had previous histoplasmosis. That's what those calcifications are, and you can see he's got cardiovascular involvement. That pleural effusion is actually it's larger, but it has been around for a while. He's had pleural thickening. And then I'll show you his skin lesion. This is his leg. And you can see these purple kind of pustular lesions, and then he's got these ulcerations with sort of sharp demarcations. Yes. So this is blastomycosis, and this man is from up north in northern Wisconsin. He's of Hmong ethnicity, and so he's actually a hunter. He goes out into the woods a lot, and many of them do. And so we've seen a fair number of cases of blastomycosis in Hmongs. But with him, because he's immune suppressed, he has a more disseminated form, and hence the skin involvement. No CNS and no bone involvement. But I know David likes to see blasto every so often, so I thought I'd show this one.
Very beautiful.
Yeah. All right, this one's pretty straightforward, but just I like to show these kind of cases. This is, let me show the radiograph. This is a man who's been treated for a cutaneous infection with daptomycin, developed some shortness of breath. On radiograph, we see this peripheral sort of consolidation and some reticulation, sort of lower lobe predominant. So we wondered about maybe some fibrosis. We have a CT scan that shows, indeed, there is a nice example of fibrosis. We have reticulation, air bronchograms, a little bit of dilated airways, but some dense areas of consolidation as well. And it's sort of in a peribronchial and peripheral distribution. Also has bad emphysema. So to me, and Seth, you can chime in, you've done a lot of this. This looks like a mixed organizing pneumonia NSIP pattern, probably with some developing fibrosis. And this is known complication of daptomycin. So, potentially he had not received steroids at this point, but hopefully a lot of this denser stuff will melt away. And but I suspect he'll be left with a little bit of fibrosis in the bases that looks awfully reminiscent of NSIP.
Always fascinating after they stop this. A lot of it's permanent, but how much goes away? Due to the surrounding alveolar collapse. It's always surprising. But
you're
give us a follow-up when he undergoes it.
Yeah, I will for sure. Okay, this is kind of a curiosity.
Did you say that guy did have some resolution, or you expected that he would?
I'm expecting that he will. They stopped the daptomycin and just started him on steroids like a day ago. So I will follow up. But I suspect he will get better. They had not put him on steroids because they were worried about it being infection, but nothing in his lungs. And he had a radiograph from a few months ago that was normal. So this is not all new. So this was just a curiosity. I've never seen this, or at least I should say noticed it before. This was just I don't remember what this was. I think it was a PE study for something. And I noticed this bizarre...
I don't see your window yet, Jeff. I don't.
Yeah.
Yeah, I can't see it.
Every time you change cases, it goes back. There you go.
Good.
I noticed this bizarre-looking inferior pulmonary vein on the right. It just almost looks like a little varix. And I thought maybe it was just going to be a hybrid with, the two branches coming in. But But if you follow it, it's really kind of a focal outpouching. Let's see if I can put it on a card as well. Kind of looks like almost like a varix. I didn't know what to make of it. I didn't think much of it. It wasn't causing any problems. But I don't know. Have you ever seen this? I've just never noticed something like this. And what would you do?
It looks like a pulmonary varix. It's a good location, and it usually accompanies mitral stenosis or mitral regurg. I wonder if he's got that, because sometimes that launches a jet that is directed into that vein. It can be the upper vein or the lower vein.
Yeah, as far as I know, there was no valvular disease, and we don't see. I mean, the left atrium isn't dilated, so we kind of argue against valvular disease. I think this patient was fairly young, or youngish. But yeah, so it's a varix. It just looks odd. I don't know of any other associations. And then this was a consult case. This was read elsewhere as cystic lung disease. As you can see, there are. Yep. There we go. There are holes in the lungs, but if you look at some of the holes, some of them aren't quite round. These are kind of tubular. So I'm going to throw it up in coronals. And I think make a mean of 2 here. Cut the noise a bit. There we go. Well, it's not great. Try this. If you look on the coronal, they look more like airways, and they're branching. So what I think this actually is a case of Williams-Campbell that sort of just slipped by over time. Oh, I got these things on. There we go. A case of Williams-Campbell syndrome, and these are sort of dilated airways further out, because we don't see normal airways that far out. And it's interesting. It's not affecting all of them. I don't know if you guys have other ideas, but to me, this looks like an airway. It is definitely an airway. In the literature,
yeah, you may recall I showed a case or two of this kind of thing before, in which I speculated that the patient may have Sjogren's syndrome. That's what I would think of when I see this, both the small cystic spaces and even the bronchi that seem to be dilated without particularly thick bronchial walls.
Okay.
And when I see this now, it's become a bit of a reflex for me. I think of Sjogren's syndrome. So this one's really interesting because it's got very similar features to one or two I've shown before.
Yeah, this is an incidental finding. You treat him for something unrelated.
Yeah.
But to me, it looks more like you said. Yeah, you're right. Some of these do look more cystic, but I can almost. And unfortunately, I don't have. These are slightly thicker slices. They're 2.5. But you can hook them all up to airways. So that's a good combo. And the list. Go ahead.
See if you can find out by history if you have a chance and a possibility as to whether he may have Sjogren's syndrome. I'm desperately looking for more cases because I have this theory about this kind of appearance.
Okay. Yeah, I mean, when I was talking to the pulmonologist, he had no history of it. This was incidentally detected. That's why I was favoring it just being an airways issue.
It's interesting that you have some foci of bronchial dilatation and then intervening knot, and it's patchy and it's here and there.
Mm-hmm.
It's very odd for something like a Williams-Campbell, because aren't there intervening segments of bronchial lumen that are not dilated?
That is correct. Like, for example...
Very strange appearance, yeah. Yeah.
Yeah, I never know what to do with this, but I've seen a couple cases like this.
Okay.
Because
interesting.
If you look at the literature, it always talks about Williams-Campbell presenting in the first year of life, and
Yep.
But we've seen a few cases in adults. All right, that's what I have this week. So Howard,
okay.
You.
I'll show a couple, then I'll stop, and then if we have time, I'll show some more. So I'll just show them in the order I happen to have them here. So the first one is going to be a patient. Sorry about that. Let me see if I can go something like, and I'm not sure why this is doing this, but if I go to no lookup table, we can scroll through there. I'm trying to remember the context in which this nodule was identified, but I can't remember. I'll see in a moment whether I can give you some more information. But here is a dominant nodule in the lingular division. It's got slightly lobulated margins, and here's another one down there. So this is March. it happens to be, at least the bigger one, is mildly FTG avid, as you can see there. And the bottom one, I can't tell if it is or is not. So mildly PET avid nodules. Let me show you another view of the lungs. And here you'll see there's that nodule there, and there's one down here. And this turns out to be, let me refresh my memory, amyloid. So let's see. Here we have a core biopsy that showed amyloid. Oh, on mass spectrometry, I guess they sent it out to a place that does that. The amyloid is consistent with light chain, and they saw a mu heavy chain, which I don't quite understand the combination of the two, and I wonder about that. But she had no findings to suggest that she has systemic amyloidosis. Well, never mind, she has a fat pad biopsy. No, that was normal. I have another case that was abnormal. So here is the path, and you can see we just basically nodular amyloid. And you can see they sent it out for typing. So a case of at least light chain AL nodular amyloidosis with nothing to suggest a lymphoma in this patient. So nice example of nodular amyloid. The next case is interesting. So I will tell you that this patient has a history of lung cancer and has been treated with different things. At a certain point in time on follow-up, he has this at the time, which was quite symptomatic. So, of course, the dominant finding is extensive confluent geographic lung glass opacity. He's got a small effusion, but the dominant finding is the parenchymal lung disease, and that is on the 30th, and this is a follow-up not too long after. So now we have on this side September 13th, so it's reversible. It goes away entirely. And we believe that this is probably a case of drug toxicity from a tyrosine kinase inhibitor called ruxolitinib. So this is one of the tyrosine kinase inhibitors. We know there's a bunch of them, Tarceva and gefitinib and some others. This is just another one, and we think this is pneumonitis from that drug. It turns out that the manufacturer has stopped development of this particular one. I'm not entirely sure why. I think because of too many adverse side effects from this particular inhibitor. So the patient was getting this in the context of a clinical trial in which they were randomized between something and this ruxolitinib. So I think the findings, at least imaging-wise, are very consistent with drug toxicity and clearly reversible. And they did stop the drug after this imaging exam was done. And in the follow-up, it's all gone. So presumed ruxolitinib pulmonary toxicity, and certainly consistent with that. That's the tumor that was treated up there. This is an interesting patient that came in. Initially, we saw the imaging findings, and they're certainly consistent with multiple, multifocal, nodular, cavitary nodular opacities. And certainly if you get any history of fever, you think septic embolism, and that's what we thought. And then not too long afterwards, one of my colleagues came by from the neuroradiology room and said, oh, have you seen this? And sure enough, I'll bring this up. And you will see that there is involvement of the right jugular vein, consistent with thrombosis or thrombophlebitis. So she's got the combination of that as well as the septic emboli in the lungs. And what was cultured here was staph. It's not that organism associated with Lemierre's disease, which is typically that fusobacterium. So the history is that she does have a PIC. She presented with neck pain and fever, has the diagnosis. They've blamed the thrombophlebitis maybe from the PIC that she has, but certainly consistent with the combination of septic emboli and jugular vein thrombosis or thrombophlebitis, as you see here. So this would, in terms of imaging, fit very nicely with the Lemierre syndrome, except she didn't initially present with a pharyngitis or an upper respiratory infection. and doesn't have the classic organism associated with Lemierre's syndrome. Okay. Should I show one more and then stop and then maybe show two more in a bit?
I have, yeah, that's fine.
Yeah, that sounds good.
Okay, I'll stop now and then let Seth go, and then if I have time, I can show a few more. That's fine. Yeah.
Okay. I have a theme today of iatrogenic wonderfulness. So this isn't, just to start off, this is an old study that I showed a couple of years ago, but one of my colleagues showed this at NASCI for most, I guess, most fascinating case, and this for, I guess, had about 10 different people from around the country show their most fascinating case. And this one, I don't know if you guys remember this. This is the person who had a fibrothorax and this really pronounced calcific pericarditis, who underwent chest tube placement, and they put the pigtail catheter straight into the left atrium from the external. So that just kind of the reminder. I don't know. I showed this a while ago. That's just anyways. So, and I have some cases that almost equal that in terms of wonderfulness. So this is a patient who was a trauma nightmare, and back in 2010, she had been had bad trauma. Let's just say it that way. And she has been scanned, I don't know how many times since 2010, but probably has had 30 CTs, numerous angiographic studies, and so you can see here that there's this metallic device straddling the left atrium here and right atrium, better seen on some other studies. So that was 2010. Here's another 2010 study, and my computer was crashing as I was trying to send over some other images, but here's another nice image of this, and it doesn't really, so it was called an atrial septal occluder device, which I can understand as it is straddling the septum, but it's odd. It's quite large. Most septal occluder devices don't kind of extend well into the atria. Let's see if I ever got this to send over. So, sorry, my computer was crashing before. 1 second. See if I can. So she had. Okay, so it did come over. So lo and behold, this has been called an atrial septal occluder device for 6-7 years. Here was a chest X-ray which shows this device. I'll send this over with the DICOM, PA and lateral. And we even have some movies showing this was patients had multiple PICs put in because she's a long-term trauma player, brain injury, and you can see this thing bouncing around here. Doesn't really look like most atrial septal occluder device. Long story short, this was a birdcage filter that had migrated from her lungs, or from her lower extremities to her IVC to her to her into a PFO, and she had been living with this for quite some time. So you can see here, I don't know why the MIPS only came over. You can see this is just a fascinating cage of a birdcage filter just sitting there in a PFO for a long time. That was missed, I can't even tell you how many times. And this was a case we just had last week, and I can't seem to find the contrast portion. We do have a contrast portion, but we were told that this patient from an outside hospital had undergone a IUD placement, and they deployed an IUD, and after they deployed it, it just disappeared. They couldn't find it. They did abdominal x-rays. They couldn't find it at all. Lo and behold, a couple weeks later, someone suggested doing a chest x-ray. They did a chest x-ray and saw this device, and so somehow this is a fallopian tube IUD wiring kind of device. it's like a Escher or Enscher or something like that. And it's a tube like a wire that's wrapped around with additional wire that you stick into the fallopian tube to prevent pregnancy. And we're not really sure how this got from what was supposed to be the fallopian tube into the IVC and hence the left pulmonary artery. But we've seen a lot of things go to the pulmonary arteries, but I haven't seen an IUD getting there yet. So that's a first on that one. And then I actually want to review a case from last week that I was wrong on, and I'm not surprised I'm wrong, not that infrequently, but this was something that really took us all aback. So I showed this last week or 2 weeks ago and said large right atrial mass, it was enhancing. I'll show you the enhancement that we didn't have the path yet, but this was going to be a myxoma. So here it is. You can see that it is enhancing. There's a lot of attenuation in there. And then I will quickly show the MR and just show the perfusion. And, oh, come on, man. Maybe I won't show the perfusion. Can I get this to play? Yeah. So slowly and surely this will hopefully play, and hopefully there'll be contrast at some point in time. So this thing is clearly perfusing. It's enhancing. It enhances on post-contrast, enhances delays. So they took this out. This turned out to be a thrombus, an absolutely massive thrombus. I didn't believe it. I talked to our pathologist, and it turns out there's a very, very small percentage of thrombus that when they organize, develop this very pronounced endothelial network. And when the pathology resident actually looked at this de novo, when they took it out, he thought it was an angiosarcoma. That's how vascular it was. But our head cardiovascular pathologist, who's quite good, said, no, it's thrombus. He even showed it to a couple buddies of his around the country, and they all said it's the exact same thing, thrombus with this pronounced endothelial differentiation within the areas of organization that leads to just microvasculature and enhancement. We've never seen anything like this. It kind of throws us off because we always assume thrombus doesn't enhance centrally. But anyways, so I was wrong. That was not a myxoma. That turned out just to be a thrombus, but needless to say, a very odd thrombus. I mean, here's the thing post-GAD. I mean, it's light bulb bright. Yeah, it's crazy. There was a term he even called endothelial papillary blah, blah, blah. I don't know. There was some term for it. You Google it. It's in the literature. And we have determined that totally ruins our world because we are always taught certain things that enhance and certain things don't. But so stand corrected. Just a thrombus.
So presumably chronic, and then it somehow has this endothelialization, small vessels.
Exactly. So, and it's weird because she doesn't have she's never had a line. We see a fair amount of right atrial thrombus, and they're almost always in the setting of something either attached to a line or attached to the crista terminalis or feeding off of coming from the IVC. But this was just sitting there. And so, yeah, it was chronic. But anyways, it's just an absolutely fascinating case from our point of view.
Maybe it's the same phenomenon that I think I recall people talking about chronic pulmonary emboli that can also somehow endothelialize or get vessels, and they enhance with contrast medium in the pulmonary arteries with chronic thromboembolism. That phenomenon, if I remember correctly.
Yeah, it's definitely possible. I mean, I have no, I would imagine it's not just associated with this kind of thrombus, that it could be associated with any thrombus, but he showed me the stains. It's calretin negative when he's, nothing's 100%, but he said, 100% of myxomas are positive for calretin, and all the other stains for myxomas are negative. It doesn't look like a myxoma under the microscope. It didn't look like one when they took it out, and he held it, and it was just thrombus.
Very interesting.
Very interesting.
Okay.
So, okay, those are the cases I got.
All right, David.
So can people see a chest röntgenogram?
We do.
We do.
So this is a guy in his 50s who had some chest pain and has this abnormal aorta on his chest radiograph, and he was CT'd, and there's a reason why his aorta looks so large. It's got this real cuff around it. He subsequently had an MR study that showed this was not an intramural hematoma. It was not. This was not a dissection. And then he has a fair amount of lymphadenopathy here. So he's got bilateral hilar lymphadenopathy, and he's got very nice mediastinal lymphadenopathy too. The lymphadenopathy looks like sarcoid. He's got some calcium in some of his nodes, and he had a positive quantiferon test. And so,
David.
Go ahead.
Also, it involves his right coronary.
Yes, it does involve his right coronary. Good point. You can see this cuff around the right coronary. So really looks like an aortitis here. So the clinicians were concerned that this was a tuberculous aortitis, and so they put him on corticosteroids to prevent a reaction to the anti-tuberculous therapy that they put him on. So he's put on several drugs and he was sent home, and he's due for some follow-up studies. But this lymphadenopathy to me really looks like sarcoid. And so I looked up some articles, and it turns out that, let me find the article here. This article shows almost identical chest radiograph and hilar lymphadenopathy here. They didn't have CT in this case. And this was a sarcoid aortitis. And I've never seen a case like this before. And, you know, he's probably going to have a mediastinoscopy now and biopsy one of those nodes. But he has not progressed to that. The notion of sarcoid was just brought up, you know, this week. So I just wonder if you guys have ever seen a case of sarcoid-induced aortitis. There is that very nice case that I just showed you, and there's scattered case reports elsewhere.
No, I haven't. I agree with you. It doesn't look like TB, especially with that symmetry and the big, fat, non-necrotic nodes.
Right, and the very, very clean outlines of the nodes, too.
And you'd also think... I'm sorry.
What?
I was going to say also, you'd think TB aortitis would give you a pericardial effusion since it's in continuity and it loves the pericardium as it is.
Right. I wouldn't expect it to be this uniform and diffuse either. You know, it would be, I thought more focal and more abscessy looking and things like that with some surrounding, you know, mediastinal disease or lung disease. So I think we'll probably have a definitive result if we get a lymph node biopsy later on, but right now it's presumed.
Wow, never seen that before, no.
Okay, and then I have this child. So this child carries a diagnosis of asthma, 11 years old, girl, and things look a little bit busy in her right lower lobe. Here she had a CT scan, and it shows some fairly fat vessels in the lower lobe on the right, and these vessels seem to go out to the pleural surface. I don't see anything coming into the lung from the chest wall. I don't see dilated intercostal vessels or anything penetrating, but she's got all these vessels that go right out to the edges of the lung posteriorly there. And I think it's just in that one location. The rest of the lung looks pretty good. And then things get dramatic here on the coronals, where we follow these vessels back. And let's skim that posterior chest wall. As we get back there, you see that there's really just a tangle of little vessels like this. So with the dilation of the central pulmonary artery and vein, I think this is a kind of AVM, but instead of having a discrete knot where there's a single connection, it really seems to be a plexus of fine connections. And so I've been looking up some literature in the last couple of days, and I think the best description of this is pulmonary telangiectasia. And there are a few case reports of this thing. There are some articles. Let me show you. This ancient article here talks about cases, and this was pre-CT, so it had angiography, but this pattern here on angiography looks very similar to, I think, what we're seeing on CT. It's just a tangle of very small subpleural vessels. And in the pathologies that they had in a couple of these things, they said innumerable subpleural vascular lesions resembling petechiae is observed on gross inspection. So I think that the term telangiectasia is accurate. These cases that are presented here are often diffuse and involve all the lobes. This one is localized. None of our angiographers has seen a case like this before, so once again I'm throwing it open to our esteemed group here for anybody else who might have seen a case that looks like this.
Nope, never. That is remarkable.
Seth is strangely silent. Seth, I'm counting on you. Dude.
He's left the county.
He's stunned. Okay. All right, those are the two cases.
Wow.
Right.
My goodness.
Thanks, David. All right, Howard, you want to do a few
Brilliant.
more?
All right, I can show the rest of mine, sure. The next one looks like this. So this looks like a person with potentially pneumonia. If the patient comes in with a cough and a fever, and the imaging findings are certainly consistent with that. So we say bad pneumonia. This is a CT in this person. And sure enough, let's just get to the pneumonia. And you look at that and say, oh, yep, definitely really bad necrotizing pneumonia. And the findings are those of the chest radiograph. But then you look elsewhere and you say, whoop, that's not the only abnormality. So, of course, the rest of the abnormalities are airway related. So pretty extensive bronchiectasis and bronchi filled with material, many generations of bronchi, very patchy. But interestingly, in the other portion of the lung, and I'm not entirely sure why this is developing, but there's some areas here that look like either really bad areas of air trapping or emphysema alike, but air trapping as well. And then small airways are involved, some bronchioles. So very much a diffuse process. And this is an acute pneumonia superimposed on that process. So certainly if you see that much bronchial and airway disease and all the other findings, one should think of repeated infections. And usually the one that I've mentioned first, and I think it's the one that's most prevalent nowadays, is to question whether this person has CVID, immunodeficiency state, and I think of CVID and ask whether they've measured the globulin level and so on and so forth. So certainly consistent with repeated infections and imaging findings consistent with that. So this one turns out to be an IgA deficiency disorder, and it's heritable. So you can see the family history of IgA deficiency. A sister has had lung transplantation. A mother died from bronchiectasis. There's the workup showing deficiency of IgA. So this is exactly that, a very unusual heritable IgA deficiency disorder producing these imaging findings.
Howard, was there an organism that was cultured here?
I don't know if we, looking down here in this pulmonary clinic note, it seems like that nothing was cultured out, so they sent him for a bunch of things, but many sputum samples, including AFB, fungus, nothing cultured out, presumably was treated with antibiotics. But no. And I'm trying to remember if I've seen a case like this before of an IgA deficiency or an exclusive IgA deficiency with the other immunoglobulin classes being normal and heritable. Very interesting case. Any thoughts just about this dramatic emphysema-like, or perhaps his bronchioles are occluded from repeated infections and he's got a lot of air trapping and alveolar air trapping from obstructive bronchiolar disease from repeated infections? I don't really know, of course, but it's pretty dramatic. There's almost like no lung tissue there, just among all the other findings that he has. I thought that was really interesting.
Mm-hmm.
Oh, and I guess he's got just a little paratracheal cyst or two as an incidental finding. All right, so really interesting. Okay,
so Howard,
go ahead.
Howard,
David,
that tracheal stuff is probably part of his chronic infection. Those are probably,
Oh, you think that this might be related up here?
Yes. Yeah, we see that in cystic fibrosis pretty regularly. So they get chronic infections of their mucosal glands, which dilate.
Oh,
Form little diverticulitis. Gas gets into them because they've been chronically infected and they're
I see.
dilated.
Oh, I see. I didn't think about that. But right here, oh, we can see the little communication there.
There are probably quite a few of them.
Let me scroll through there a little bit. Okay. 1, 2, 3. You can see the little communication there. Oh, I must say I didn't associate that necessarily. I thought I was just seeing an incidental finding. But you've seen them, sorry, you were saying you see them in the context of what, David, again?
Perhaps? I see them in cystic fibrosis all the time. So
bronchial disease.
It's part of the, and actually those mucosal glands are a source of infection. When you transplant both lungs in cystic fibrosis, you're trying to get rid of as much of the infected tissue as you can, but you leave behind the trachea and bronchi, and sometimes they will infect their lungs from that tracheal location, those infected submucosal glands.
Okay. Oh, didn't think about that. Good. Okay, another case of amyloidosis. This person actually presented quite a long time ago with severe cardiac amyloidosis leading to heart failure, and I think subsequently, if I remember correctly, he did have cardiac transplantation, but this goes back to 2008 at the time that he has a big heart. So let me show you the chest radiograph, because this is a super nice example of a septal pattern of what we would guess I'd call alveolar septal amyloidosis. But I really like the word septal applied to this patient because these are beautiful, not too many, but beautiful septal lines. So I don't think he's ever had a lung biopsy, I don't think, but this is a transthyretin amyloidosis. You can see he's had a heart transplant, and I think a reasonable assumption is that these septa contain the amyloid protein. For that, it's just a particularly nice example of septal lines, but they're quite focal in the lungs. And I don't know if he had a biopsy. Let me see. Oh, he did have a bronchoscopic biopsy in 2014 that showed amyloid. So a really nice example of the septal pattern, at least in this patient with the TTR amyloidosis, as you can see there. And his son was diagnosed with it. So certainly you can get a heritable form of TTR amyloidosis. So a nice example of that. All right, this is a really nice case. We've shown a few of these before. So let me just put up the frontal and lateral together and just give you a moment to look at that and what you might say when you see and confronted with a chest radiograph that looks like that. And you can see there are lots of clips in the right upper quadrant, but this shouldn't be there. And depending on the presentation and the history, and we know there's been a lot of surgery there. And if this is new from before, you wonder about the integrity of that right hemidiaphragm and where bowel is located. And indeed, here you can see where the bowel is located. And as I scroll back here, you can see the defect in that right hemidiaphragm is really quite large. So a lot of bowel goes up there, some mesenteric fat goes up there. The bowel is not ischemic, it's a big hole. And you can see how big that hole is, and you can see there's no right hepatic lobe there. So this turns out to be a really nice example of an iatrogenic injury to the diaphragm. from the right liver lobectomy. And of course, there's not going to be peritoneum there because it's injured, and whatever herniates up there will just go up there without having a nice hernia sac. And you can see that was in fact the case, no associated hernia sac. So we've seen a couple of these at our conference, and this is just another one, an iatrogenic large diaphragmatic defect that was fixed. So a really nice example of that. And having the history is really key here in figuring it out. So a nice example of that.
Okay.
Okay, Jeff, those are mine.
All right. Well, thanks everybody, and I won't be here next week, but Travis said he'd be back, and so continue on without me, and I'll talk to you the week after.
All right. Thanks, guys.
Bye.
Thank you. Thanks, everyone.